NHTD and TBI Waiver 101 training. If you are watching this, you are on mute, and if you have any questions, if you look on your screen, there's a place where you can type in questions. So I do have somebody monitoring questions. If you have any questions during the presentation, please feel free to ask them, and then I will be able to answer them. And as well, I'll make sure at the end to ask if you have any questions. So again, we're going to be doing NHTD and TBI 101. This is a really basic training, so for anyone who is already working in either of these waivers, this is probably repetitive and things that you already know. So I'll just put that out there. You don't have to attend this if you already are familiar with these. And for those of you who are familiar, you will notice that this training has been heavily borrowed from the NHTD Waiver 101 training. So to get started, this is part of the MFP, the Money Follows the Person Transition Center project. And again, this is just meant to get everyone on the same level before we have our big conference in January. So the first thing that you need to know about NHTD and TBI waivers is that they are a Medicaid waiver. In order to understand what a Medicaid waiver is, you need to have a basic understanding of what Medicaid is. So Medicaid is a health insurance program. It's federally funded, but it's run by states and counties. This medical insurance is meant to be for individuals with low income, but you can have Medicaid with other kinds of insurances. You can have Medicare, you can have any kind of third-party insurance, Blue Cross Blue Shield, United Healthcare, whatever it might be. But the concept is that Medicaid, because it is meant to be a low-income source of health insurance, should always be the provider of last resort. So they're going to go through all your other insurances first before Medicaid will pay anything. And what you will find, surprisingly enough to me, is that if you ask an individual if they have Medicaid, they may or may not know, or they might be confused with Medicare because they sound so similar. So from what I've found, the easiest way to tell if somebody has Medicaid or not is ask them if they have an insurance number that looks like 2 letters, 5 digits, and then another letter. Or if you ask them, do they have a card that has a big word benefits across the whole card. That's another way to kind of assess whether or not they have Medicaid or have a good guess about whether they have Medicaid. So what does Medicaid cover? Medicaid covers the same things that any other insurance covers. So you think about whether you're going to the doctor, whether you're going to the dentist, you're going to, get your medications. If you need things like crutches or canes, it covers all those sorts of things. Medicaid also covers home care. Most other insurances will cover sort of acute, intense, medically driven home care, but they won't cover personal care aids, somebody to help you cook or clean your home, those sorts of things. But Medicaid does cover that kind of personal care aid home care. They also cover if you go to the hospital, you have an accident, you go to the ER, you take an ambulance, all those things are covered. And nursing home care is covered. And in fact, about 80% of people in nursing homes in New York State are on Medicaid. All right, so what's a waiver program? Waiver program means that New York State has asked, the federal government has asked CMS, which stands for Center for Medicaid and Medicare Services, to use those Medicaid dollars, not just for the things that Medicaid normally covers, they call those Medicaid state plan services, but for other things, for additional things. And they want to ask for those additional things to be covered for a specific reason. So the specific reason that they want to cover different things other than what regular Medicaid would cover is because the individual that they want to have in this waiver program is at risk of being in an institution. Now, an institution can be a nursing home, it can be an ICF, it can be a developmental center, but it's some kind of institutional setting that you're trying to avoid. And the individual must be in the community, which again means not in an institution. But this can be really anything in the community, anywhere you would live, a home, an apartment, a hotel, a boarding home, anything like that. And it can also mean an IRA as long as that IRA has 4 people or less in terms of MFP. The other thing about waivers is that they have to be voluntary. You cannot force anyone to be in a waiver. So I know this has come up in the past where you know, an administrator, you know, somebody official would say, oh, well, Mrs. Smith really should be on the NHTD waiver or the TBI waiver because she needs all these services. But if Mrs. Smith does not want to be on the waiver, then it's you stop there because it is voluntary. All waivers are voluntary in nature. And the other characteristic about waivers is that they are for a specific population. Next slide. The specific populations in New York State, you'll see a list here of all the populations in New York State that New York State has requested waivers for. So NHTD waiver and TBI waiver are the ones we're going to be talking about today, but there's also OPWDD, which is the waiver for individuals with developmental disabilities. There's Care at Home, which is really just a piece of OPWDD. It's managed by the same people at OPWDD, but it's for children, and they usually have significant medical issues. Bridges to Health is another children's program, and it's for children in the foster care system. Then there's also an OMH waiver for children, and there's something called the LTHHC, the Long-Term Home Health Care Program. That, however, has been transitioning to managed long-term care, so you probably won't be hearing as much about that. That's also sometimes called the Lombardi waiver. All right, so what's the waiver philosophy? From the waiver perspective, the participant, the individual that, oops, sorry, I skipped the slide on you. All right, so waiver programs. All right, so when would you use a waiver program? The reason that you would use a waiver program is because if those Medicaid state plan services, those normal Medicaid services, aren't enough for the individual to live in the community, they would have to be institutionalized if they did not have these services. Now, the whole premise is that living in an institution, living in a nursing home is quite expensive to Medicaid, and the advocates have argued over and over again it's cheaper to have somebody live in the community than it is to have them live in the nursing home. And as long as you've got somebody who wants to live in the community and wants to be on the waiver, that's advantageous to everyone. So these waivers have to be what they call cost neutral. How the waivers have defined that is that the average cost of all the people on the waiver has to be less than $250 per day. Those are the Medicaid costs for the individual. Now, that does not mean that you can't have any particular individual whose average daily cost is more than $250. It's just that the average of everybody. So if you have somebody who's costing, say, $400 a day, then you better also have somebody who's costing closer to $50 a day. And obviously that's not our responsibility. That's the responsibility of the state and the RDCs to manage those average costs. And I've never heard that we're having a problem with that. So I wouldn't worry too much about what the cost is, but just know that there is a cap on there. So where did waivers come from? Waivers came really as a result of advocates going to the legislatures and saying, we need options. You know, there's people in nursing homes that don't want to be in nursing homes, but for these services, they could live in the community. And that's how waivers get started. Now, the independent living centers really have been a driving force in getting these waivers up and running. So when you hear all this kind of waiver philosophy, you should all kind of sit out there and go, yes, that's who we are, that's what we do. It really should be comfortable for the IL community. at least specifically for the NHTD waiver, I know that there was some concerns that the Lombardi waiver, the LTHHC that I mentioned before, wasn't really meeting the needs. So even though there was an existing waiver, there were caps on how much aid services you could get. There was a real kind of medical model feel to it. So the NHTD was partly a result of that, and also partly a result of people saying that the TBI waiver worked really well, but that you couldn't get on the TBI waiver unless you had a brain injury, and there was other people in nursing homes that could use those similar services, but they had, let's say, something that wasn't a brain injury. Let's say they had diabetes or hypertension or something cardiac going on, so they wouldn't be eligible for the TBI waiver. So when did these waivers start? TBI started back in the mid-90s, and then NHTD, like I said, kind of came as a result of people saying TBI for other people with physical disabilities would be a good idea, and that started in 2008. All right, so the waiver philosophy is, and again, those of us in IL should be very familiar with this, but the participant, the individual, really is the primary decision maker. They are the ones who are going to define what they want, what services they do want, what services they don't want, where they want to live, which doctors they want to use. All of those things really should be the decision of the individual. There's also the concepts of dignity of risk and right to fail. Sometimes people in nursing homes or in institutional settings feel, well, you can't let Mrs. Smith live in her own apartment. She might fall and break a hip. Well, Mrs. Smith has the right to say, yes, I want to take that risk. And by the way, I could fall in the nursing home and break my hip too. So that right to take a risk, that right to fail, is the individual's. It's not yours, it's not mine, it's their own right. And you know, I challenge anyone to say that they've never tried something that they failed at. You know, so saying that we have to write a plan that's absolutely foolproof, that will never ever fail, that's a standard that you don't have to meet. It really, again, goes back to the individual's choice. You know, this plan may or may not work. I recognize that. I'm informed about that possibility, but I want to try it. I think there's a good chance it'll work. I want to try it. Again, it's the individual's choice. The concept of independence, again, going back to independent living philosophy, that there's a very strongly held belief that people should be as independent as possible. Anything that they can do on their own, whether it's with some kind of assistive technology, you know, but whatever they can do on their own, they should be doing on their own, and that's preferable to having someone else do it for you. The concept of community involvement. That, again, goes back to the individual. What is meaningful for the person? So where one person might say, well, what's meaningful to me is being able to go to church on Sunday, someone else might say, well, what's meaningful to me is that I get to watch my soaps at 1 o'clock. It really depends on the individual, and that's what a plan should do, is make sure that the involvement that the person has is based on what they want, not some kind of external idea of what people should be doing. Next slide. Another important concept in the waivers is the concept of health and welfare. They kind of got away from using the word safety because, again, no one can really assure someone's entire safety. You know, I could fall down the stairs tomorrow, so could you, so could anyone else. So it's really about maintaining their health and welfare and making sure that there's a reasonable plan to make sure that that's going to happen. So it's things like making sure that they have, you know, doctors and providers, and making sure there's a safe place to live. I think we can all agree that saying someone's going to be discharged to a homeless shelter would not be really assuring their health and welfare. You want to make sure that they have the basics kind of all covered. Now, how is this waiver administered? What's the kind of administrative structure? There are things called RRDCs, which stands for Regional Resource Development Centers. They are the local level administrators of this waiver. So these are the people who take the initial referral. They determine, it's kind of a preliminary eligibility. It's not that they have been accepted onto the waiver, because you don't actually get accepted onto the waiver until a service coordinator has written your plan and that plan has been approved. So, but they do go out and say, yes, we see that this individual, they have Medicaid, they want to live in the community, they have some kind of medical condition that would make them eligible for the waiver, and we think that with the waiver they would be able to live in the community and have their health and welfare assured. So that they kind of ask these very basic questions and determine that preliminary eligibility. The result of that meeting is that the individual then gets a letter that says, go ahead, pick a service coordinator. And that's a lot of where we're going to be getting involved, is helping people through that initial referral place and getting their service coordinator. And the RRDC is also the place that approves the plans, and the plans are what include the services, the waiver services. So they're the ones saying, yes, you're approved for 10 hours of HCSS or whatever particular service. The RRDC also has a nurse evaluator. So this is a nurse that works at the RRDC, and so when anyone has a plan or an individual they're working with a lot of complex medical issues, the nurse is going to review that because it's just a good idea to have somebody with a medical background go over it and make sure you kind of haven't missed anything and you've got everything set up for the individual. So they do provide technical support to the service coordinators. If the service coordinator has a question, what should I do about this person with a stage 4 wound? Is this plan adequate? They can answer those questions. They also review all the UASs, the Uniform Assessment System. The UAS and PRN screen are the two eligibility criteria that determine whether someone actually meets level of care or meets the criteria for being in the waiver. So the nurse evaluator is one who looks at all of those. And in the exception, and it can't be the rule, but in the exception, when no one at the county or at a CHA is able to complete the UAS, the nurse evaluator can help out in that circumstance. All right. Then we have the Department of Health. So the RRDC is, like I said, sort of the local level administrators. Then the Department of Health is who is contracting with the waiver service, with the RRDCs. So they oversee the RRDCs, and they are making all the policies that the RRDCs and that everyone in the waiver has to follow. Next slide. All right, so eligibility. Who is eligible to be in the TBI and NHTD waiver? And again, NHTD kind of grew out of TBI, so some of the criteria are very similar. So we're going to start with all the criteria that are exactly the same. So in order to be in the Medicaid, in a Medicaid waiver, you have to have Medicaid. Seems obvious, but you can't have an alternate service to the regular Medicaid services unless you actually have the Medicaid to begin with. You do have to be over the age of 18, and you do have to meet the level of care to be in a nursing home or institutional setting. And you, the individual, have to choose to live in the community. Now, there are some circumstances where the individual has cognitive limitations, so it might be a family member who is saying, yes, we know mom's, not able to communicate really well, but she's always said she wants to stay in her home. That is acceptable too. If you have a family member, an advocate who says yes, or a healthcare proxy who can indicate for the individual that they would want to be in the community. The needs actually have to be able to be met in the community. You can't, again, have someone whose needs are so high that they can't be, their health and welfare can't be assured in the community. They do need to have a safe place to live, and this seems obvious, but in order to be on the waiver, you actually have to need waiver services, at least one waiver service per month, because why would you be on the waiver if you don't need the services? Kind of makes sense. Next slide. So for the TBI waiver only, you have to be between the ages of 18 and 64 when you are accepted onto the waiver. So you can actually be 65 or over when you've been on the waiver for a while and now you've turned over 65. It's not that they kick you off, but this was actually one of the concerns that started the NHTD waiver, because people who are older, even if they had a TBI, couldn't get onto the waiver. So there is that kind of criteria of age for the TBI waiver only. And as the title of the waiver would indicate, you have to have a traumatic brain injury, and that traumatic brain injury has to have happened to you after the age of 18. If the injury happened before the age of 18, you would be eligible for OPWDD services. Now, for the TBI, currently they use the PRI and screen to determine whether you meet nursing home level of care. They're trying to switch that over to the UAS, but there's a lot of concern from the provider community that the UAS really doesn't assess the cognitive issues that individuals with TBI have. So there's kind of a lot of pushback to keep using the PRI and screen. So currently you can use the PRI and screen, but that, again, is for TBI only. For NHTD, you can be any age over the age of 18. And we have a question. It says, it was my understanding that if a program is funded through Medicaid, that you must also offer services to someone who does not have Medicaid. In other words, you cannot turn someone away solely because they do not have Medicaid. Well, actually, in this case, you have to have Medicaid because it's a Medicaid waiver. These services are paid for by Medicaid, so you can't get these services unless you have Medicaid, because there is no other funding stream for them. So I hope that clarifies that question. So going back to NHTD. So again, you can be any age over the age of 18. Again, for NHTD, you have to have a UAS, and your score has to be 5 or higher to meet level of care for NHTD. And if you are under 65, you have to have the diagnosis of a physical disability. So if you're over 65, in theory, you don't have to have the diagnosis of some kind of physical disability. I think of it from a reality perspective that when we go back to the criteria that you have to need a waiver service, I'm not sure why you would want any of these waiver services if you didn't have something physical going on. You know, if there wasn't, whether it's cognitive, physical, some kind of disability happening, you probably wouldn't want the waiver service to begin with. So to me, I can't think of anyone that I've worked with on the NHTD waiver who was over 65 who didn't have some sort of physical disability or some sort of cognitive disability going on. Next. All right. So this is a very important concept, and that is that you can only be on one waiver. I think of it in terms of pick your waiver, right? You cannot be on 2 waivers at any given moment in time. Now, the way that NHTD and TBI waivers are set up, you actually can be eligible for both. If you're an individual with a brain injury, you can absolutely be eligible for both waivers at the same exact time, but you cannot be on both waivers. You have to pick. You have to decide which one is going to work best for you. And how you determine which one's going to work best for you is the services under each one are not exactly the same. There are some services that are exclusive, and we'll go through exactly what the differences are to one waiver or the other. The other thing is the providers. There are some providers who will work only with TBI or work only with NHTD, even if it's the same service. The service is offered by both waivers. So you want to figure out who's going to be the best provider for this individual. The bottom line is that it comes down to the individual's choice. Now, you can switch between waivers, but that's not something you should kind of like, well, this month I'll be on NHTD, next month I'll be on TBI, then I'll switch back to NHTD. You kind of want to, find what works for the person, and then if a person has not doing well or something has changed and you need to switch because, let's say, they need a service that's only available on TBI or NHTD, then you switch for that reason, but you don't want to kind of be switching back and forth. All right, so we have a couple of questions. is it required that a resident have a natural or informal support? It is not a requirement of the NHTD or TBI waiver that they have a natural or informal support. However, most aid agencies, if you've got somebody who has who needs aid services, which a very large number of individuals on the NHTD or TBI waiver need aid services. A lot of the aid agencies won't allow you to get services from them unless you have some sort of backup system. We're actually talking about creative ways to create those informal supports because that is definitely an issue. So even though it's not formally a requirement, in effect it can become a requirement. I hope that answers that question. And it says the slide numbers are on the bottom. It's like in an orange color. I don't know if you guys can see that, but we're on slide 17. Can somebody respond back if they can see the slides at the bottom in orange? Yes. All right. Somebody replied back that we can see them. All right. So in orange, you should be able to see the slide numbers. Oh, but if you're wanting me to say them, oh, I get it. I get it. Okay. So we are on slide 17. Now we're on slide 18. It's a little hard to do this just talking to myself, so I apologize. Now there's another question. SEMP is a waiver service as well, and we can't turn someone away because they are not in waiver. Medicaid waiver is based on medical necessity, so it would be like going to a hospital. You cannot turn away if they do not have Medicaid. Don't want to challenge you. Just clarify. I do realize that most people have Medicaid, but there will be some people who do not that will need the service. SEMP is not a NHTD or TBI waiver service. SEMP is a OPWD waiver service, and there's also SEMP that's part of Access VR. But the truth is that, well, first of all, you can turn someone away from getting SEMP because they don't have Medicaid because you can't bill for SEMP. You can't bill for OPWD waiver service SEMP. So even if you create an alternate, or a mirror service, then where you can serve people who are in a SEMP-like service, and maybe that's 100% state funded. It's not Medicaid waiver SEMP. So the person who's asking these questions, maybe you and I can have a conversation later. We're probably a little bit in the weeds in terms of the Waiver 101 conversation, but it is absolutely true that you have to have Medicaid to be on a Medicaid waiver. Okay, so going back to NHTD and TBI services. Many of the, hello? Can people still hear me? I just heard a beep that sounded like, am I still on? Yes, okay, I'm still on. NHTD and TBI services. Many of these services are both offered by NHTD and TBI. Because there's this concern that there's some providers that only do one or the other, you really need to have your regional list, or the RDC puts out a list of who provides what services, and really be aware that not all services are offered in every area. So as much as we're going to go through, hey, here's all the services that are available, be aware that you may not be able to get them in your area just because there are no providers. All right, so these are, next slide, these are the services that are offered by both NHTD and TBI. So, we are now on slide 20. Service coordination is the person who helps to write the plan. That's kind of the key person, and it's the equivalent of an MSC in the OPWD world. They're the one who figures out who the providers are, makes sure that they're doing what they're supposed to be doing. This, generally speaking, is a monthly service, So the minimum billing standard is that the person, the service coordinator, sees the individual at least once in the month that they bill for this service. I have to say that in my experience, it's not once a month. It's many more times than once a month, but that is the minimum according to Medicaid. The other thing to know about service coordinators is who you have as your service coordinator is very important. It really does have to be somebody that you personally can work with, that you like, because the individual, and when I say you, I mean that I'm talking about the individual who's the participant here. But the participant is going to be working with this person over time. They really need to have confidence in them that this individual is going to get them what they need. So one of the things that MFP is going to be doing is helping individuals select service coordinators that are a good match for them. Next slide. ILST, Independent Living Skills Training. This is a goal-directed service. So you have to have something that you want to do, something you want to learn. So if you imagine that someone, let's say, has a stroke, right? So I always have known how to make a sandwich, but now I need to know how to make a sandwich when I don't have the use of my right arm. And this can be the ILST can come in and help you learn how to make a sandwich, and they can make recommendations for assistive tech, which we'll talk a little bit more about later. But they can say, well, it would be much easier if you make a sandwich if you use a plate that has the rims on it, so that when you slide the peanut, or when you spread the peanut butter on, the bread doesn't go sliding all over the place. It can be travel training. They can set up systems for you. So when you think about TBI, people with cognitive issues, they might have trouble remembering to do certain things. They might have trouble remembering whether something as simple as did they eat lunch or not, right? So the ILST can come in and create a system for them, like let's say a checkbox, where every time they eat a meal, they go and they check it off, so that if the individual can't remember if they ate or not, they can just go back to the sheet and check, oh yes, I already had lunch, I'm good. So that's what an ILST does. It's a teaching, it's a learning thing, and those goals really should be individualized to the person. Now, when you're getting someone out of the nursing home, and again, this is just an experience thing, there's usually a whole host of things that the individual wants to learn to do, but you kind of have to prioritize. And the way I think of prioritizing is, what's the first step? What do I need first in order to do all the other things? So the best example I can give of that is transportation, right? So if you have somebody who wants to be able to, they want to live on their own, cook their own meals, et cetera, getting to the store, you might say, well, if they can't get to the store, if they can't go on transportation, that's going to make it harder. But we have these other systems in place. We have aides who can go do the shopping, at least while they're learning to do the travel part of it, right? And so you might say, well, the travel part of it we're going to prioritize, and then we're going to work on the cooking part of it, right? So, and obviously it's individualized to a particular person, but you want to make sure that you do it in some sort of logical order. You can't kind of just throw everything in there all at once. And you'll see on these slides, I did try and put in what the OPWD equivalent was, because I'm assuming some people on the call are familiar with the OPWD system, but not the NHTD TBI waiver. So this is sort of like ComHab and ResHab in that system. So HCSS, I have to say this was the thing that was the most challenging. This concept of HCSS was the most challenging for me to learn. So hopefully the way I explain it will make sense to everybody, because this is how I finally learned it. So an HCSS, a Home and Community Support Services person, is the exact same thing as a personal care aide. So when you think about aides in the home, they can help you with your ADLs, your IDLs, but the difference between a regular PCA and an HCSS is that they can also do something that they call oversight and supervision. And what that means is that if you think about how aid services are allocated, how you get the number of hours that you're supposed to be able to get from an aide, right? The nurse comes in and they say to you, all right, what do you need help with? You need help brushing your hair, brushing your teeth, taking a shower, and then they assign minutes to that. And that's how they get to the total number of hours. But it's all these tasks, right? If in addition to all this help with tasks, you also need someone there just in case, right? So you have someone with cognitive issues who might leave the stove on, might wander off and not know how to get back home, right? They have cognitive things going on. A lot of times people think of this in terms of dementia, but you kind of need someone there just in case something happens, not necessarily because there's another task that needs to be done. That is, in a nutshell, oversight and supervision. And so the actual physical person is the same person. The aide they do all exactly the same things as the aide. They are the aide, but you've got this additional oversight and supervision component to it. Now, the one sort of caveat to HCSS is that it really is supposed to be you either have HCSS or you have PCA, right? You're not really supposed to be mixing them. And if you need HCSS, that sort of supersedes the PCA. And again, the HCSS person does all the PCA stuff. However, if there is something that needs to happen that a PCA can't do, so med administration is really the easiest example of that. You need somebody to help you with your meds. A CD pass can do higher levels of care that aides are not allowed to. In that case, you can have both HCSS and PCA, again, the PCA that's run through consumer directed, because you need that higher level of care. So they allow you to break it out in that one kind of very specific. But generally speaking, HCSS and PCA, or HCSS takes the place of PCA. Next slide. What number are we on? 23. We're on slide 23 now. PBIS, Positive Behavior Interventions and Supports. This is for any individual who is having behavioral challenges. And I always like to think of PBIS as really a lot more about the people around the participant than the participant themselves. As much as their skills, et cetera, that you could be teaching the individual, a lot of it is about writing a plan so that everyone knows, everyone's on the same page. Because if you have a person, let's say, who has a TBI and they get upset when the routine changes, because you have to imagine from their perspective, they have a hard enough time kind of keeping cognitive track of things, right? And then all of a sudden you change the routine, that's going to be upsetting to them. So things as simple as training the caregivers, hey, we're going to have a schedule, we're going to stick to this schedule, and if there's a change in the schedule, this is how you let them know, and we're going to write it down for them in this special book so they can track it, things like that. So, so PBS does teach the individuals skills, et cetera, to deal with behavioral challenges, but again, it also really can be nice in terms of creating a behavior plan and giving some training to the caregivers. Next. Structured day program there are day programs that are funded by Medicaid, but most of them have a medical model, so it's all about making sure that you got fed, that your basic needs were cared for, and they're not really meant for people who don't have sort of those ongoing medical needs. Structured day program services, however, are really based on socialization. It's a social model. So even though some of that other stuff can still get taken care of, the primary reason for a social model or a structured day program is so that the individual can socialize and go play bingo with their friends or whatever it might be. So that's the difference between just a regular day program and a structured day program. And this is sort of the very, very rough equivalent of day hab in the OPWD world. assistive tech, which I referred to a few times, and I think that the reason I end up referring to it is because it really is a way of helping people be independent. So assistive tech is any kind of equipment, and you don't have to think in terms of technology like high tech, any kind of equipment that's going to help the person be more independent. And it's kind of unlimited what's out there, and it's actually kind of amazing what's out there. So it can be something as simple as a talking clock. So for someone who has a visual impairment and they can't see the clock, you can have a clock that you push the button and it tells you what time it is. It can be the PERS, the Personal Emergency Response System, which I always think of as Lifeline. You know, the necklace or the bracelet that you wear so that if you know, the old commercials I found and I can't get up, it calls 911 for you. That's assistive technology. Things like specialized plates, again, so your sandwich doesn't slide off. And there are assistive technology OTRs, occupational therapists, who will go through and do an entire assessment and say, hey, here's all the equipment that you could use that would allow you to be more independent. But again, the caveat, and it's really for this and for every other Medicaid service, is that you're supposed to make sure that there's no other source to pay for these items, including Medicaid, right? So I think we can all agree that some of these things are fairly obvious. Medicaid, there's no code for a talking clock. But, you know, with things that are like a bed, for example, a bed Medicaid will pay for, but you might need a specialized bed that Medicaid won't pay for, in which case it would be assistive tech, but you have to go through Medicaid first, get the denial, and then say, okay, well, since Medicaid won't pay for it, I need the waiver services of assistive tech. All right, we're on slide 26, EMODs. Environmental modifications, and probably a lot of you are familiar with these. OPWD has these, Access to Home does EMODs, and it is any kind of modification made to the home. It does not have to be the home that you own. It can be an apartment, something that you lease or rent, but in those cases you have to get the permission of the landlord, obviously, and it's any kind of modification made to the home to make it more accessible. And the EMODs can be small or they can be big. It can be as simple as putting in grab bars in the bathroom so that they can get to the toilet more safely. It can be as big as remodeling an entire bathroom so that they can have a roll-in shower and one of the toilets that are higher up and have a sink that they're able to roll under. It can be any number of things. They also have things like track lift systems where an individual can go from room to room with a track lift in the ceiling. So it's really pretty open in terms of what the modifications are. The one restriction is that you can't add space to the home. So you can't like say, well, we're going to add an extra room for this individual. It's got to be within the original footprint of the house. CTS. This is a great service. If you think about people who have been in nursing homes for a period of time, which is most of the people that we're talking about getting out, if you were living in an apartment and you went into a nursing home, let's just pick a random number, let's say you were there for 2 years. When you move into that nursing home, what happens to your couch and your kitchen table and your bed, and right? If you are living on a fixed income and that money is going to the nursing home, the chances of you being able to store all these basic household items is very small, right? It's just a storage unit. You could say, oh, well, they should rent a storage unit. That's a lot of money. So there's a huge number of people in nursing homes that have basically lost all their bigger household items. You know, they probably have kept their pictures and their license and the small things that they can keep in the room at the nursing home, but the bigger stuff a lot of times they no longer have. So one of the barriers to getting out of a nursing home is that they don't have all those basic household furnishings, and that is what CTS pays for. The other thing that's hard for people who've been in a nursing home for a while is saving up the money to live in or to pay for a security deposit or any other kind of deposit. If you've got a personal allowance of $50 a month, saving up for, say, an $800 deposit is next to impossible. So that's what CTS pays for, and the thing you need to know is that this is a one-time service. You only get it once when you move out of the nursing home, and so you better make sure you've got everything you need on the list, because you can't then go back and say, oh, but we forgot to get them a chair to sit in, or we forgot to get a kitchen table, whatever it might be. You really do need to make sure that you've kind of got everything on that list, and everything should be something that the individual wants or individual needs. And the one restriction on CTS is that it can't pay for entertainment. So TVs, right? Most people, I would say, have a TV in their house, or some way of watching TV, or maybe it's a computer nowadays. But so I know we just had Christmas, and people probably got new fancy flat screen somethings, but you may want to think about donating your older TV, because that's one thing we can't get with CTS. So I'll just put that small plug out there. You might want to just save those, because there'll be people who need them. Oh, CTS, Community Transition Services. Oh, is there a cap on the amount for CTS? It is $5,000 for NHTD, and I believe TBI is the same. But it's not a huge amount of money, but it is, in most cases, it's enough to get you started. And in my mind, it's better than zero. Oh, well, we talked about security. It can pay for the security deposit, utility deposits. Oh, and you can also, let's say that you have somebody who has a home in the community, but we'll say it's a townhouse that's all on the second floor, and the individual now uses a wheelchair, so they need to move to an apartment that's or a house that's on all one level. So you actually can pay for a mover with CTS in that circumstance to move their belongings from one place to another, if the reason that they're moving is somehow related to the disability. All right, next slide. Respite Services. So a lot of the individuals that you'll be working with have non-paid caregivers. And anyone who's done caregiving knows that you do need a break. You can't just kind of do it 24/7 and say, oh, well, you don't ever need a break. Respite is basically a break for those non-paid caregivers. It is approved in 24-hour blocks, and how it actually happens is that you have an aid agency that will send aides into the home. It's a little bit different than what OPWD, individuals on OPWD might be used to, which is usually a center-based respite where you go to a particular place for respite. This is actually provided in the home, again, by an aid agency. CIC, Community Integration Counseling, is different than counseling because it's really focused on the disability. So these are counselors who have experience with disabilities, and it's focused on the differences that the individual is having to deal with. So it can be things like, I was 18 when I was in a skiing accident, and I was planning on going to college and to be a personal trainer or something, and now that can't happen, and I have feelings, et cetera, surrounding that. Or, I go into a restaurant, and because I'm using wheelchair, people talk to my companion instead of me when they're asking, what do I want for lunch? And that just makes me so angry. So it's those kinds of things that the CIC is supposed to focus on. The nice thing about CIC is that in addition to being for the individual, it can also be for the family members. So again, going back to the 18-year-old, who has a serious accident, the parents are feeling like, oh, I have all these hopes and dreams for my son or daughter, and that's now changed, and instead of, him or he or she going off to college, now they're staying home with me, or or it could be as simple as, I don't think that they can, I'm afraid I don't think they can move to their own apartment because something might happen. I've been caring for them ever since they had this accident, things like that. So CIC can be for the individual or for the family members or caregivers. And this service, you can do it in the individual's home, or you can meet somewhere in the community. It's not the same as having to go to your local mental health center. All right, so these services are the TBI only services. These next two services can only be received if you are on the TBI waiver, not the NHTD waiver. Now we're on slide 31, Waiver Transportation. So most of you should be aware that Medicaid provides transportation for medical reasons. So you can get a Medicaid cab that takes you to the doctor, the dentist, the OT, the PT. But heaven forbid you should actually want to go get some groceries. You're out of luck, right? So waiver transportation is non-medical transportation that is paid by the waiver. It can be for entertainment, socialization, shopping. Think of all the places that you go on a daily or weekly basis. So it's actually a really nice service. And again, when you're thinking about should someone be on TBI or NHTD and they have a brain injury, you might want to consider, would waiver transportation make a difference for this person, or is there like a really good public transportation system near where they're living, and so they don't really need this extra waiver transportation. Next slide. TBI also has substance abuse program services. So if you think about what, and I hate the word normal, but a normal substance abuse program service looks like, most substance abuse programs are very cognitively based, right? They're going to teach you new skills and different ways of doing things, right? Well, if you're an individual with a TBI and you have cognitive issues as a result of that, those kind of regular substance abuse programs aren't necessarily going to work for you. It's just a different way of doing things to do it for someone with a TBI, and having and I think that this really again came out as a part of the advocacy, that's one of the issues that people with TBI deal with in terms of the services not matching their needs. So these programs were really developed to meet the needs of the individuals with TBI. And again, I keep saying this over and over again, but there's this whole idea that family members can be a part of this, right? So your typical substance abuse program is all about the individual. They have to make better choices, how are they going to think about things differently, et cetera. But they can actually work with the family members and talk about, well, even though he's made a commitment to remain sober and he knows that, drinking isn't good for him, and it has all these negative consequences for him, then tomorrow morning when he wakes up, he won't necessarily remember that that's what he wants. And so if there's beer in the house, he's going to drink it. It's, it's going to happen. So, the substance abuse program services can also work with family members in terms of what they should be doing differently. So it might be as simple as there's no more beer in the house because it just is not going to work for the individual. All right, so those two are the only two services that are for TBI only. NHTD has several services that are specific only to NHTD. Respiratory therapy is where a respiratory therapist comes and meets with you, and it's supposed to be all about maintaining your airway, how you use your oxygen, that sort of thing. The thing you should know, though, remember that waiver services should only be used if there's not a Medicaid state plan service that's available for it. If you get oxygen, you can get a respiratory therapist. The oxygen companies provide a respiratory therapist for you. So for most individuals, that particular route is going to work for them rather than having to go through the respiratory therapy waiver service. Next slide. Home visits by medical personnel. I have to say, when I first read this service in the NHTD waiver, I was so excited because it's such a great idea. This is where, whether it's a doctor, physician's assistant, nurse practitioner, a medical professional comes to you, right? Imagine if you're sick enough to need to see the doctor, how nice would it be if they came to you instead of you had to go into the doctor's office, right? And they're supposed to evaluate you in the home and provide any kind of training that you need. They're, prescribe medication, whatever it might be. So like I said, when I first read this, I was like, that's a great idea. However, the reimbursement rate is $40 per visit. The results of that is that, and I've yet to hear, and maybe somebody on this call knows, I've yet to hear of any actual providers. Somebody said to me there might be some in New York City, but there's few, if any, providers of this in the state. And again, in my opinion, that's a result of the reimbursement rate more than anything else. Next slide. Congregate and home delivered meals. Most people are familiar with Meals on Wheels or home delivered meals through the Office for Aging. However, you have to be over age of 60. So again, remember that these waivers, you can be anything over 18. So if you're, say, 40 years old and that you really need this service, you can't get it through Office for Aging. So this is really just a mirror image of that, the Meals on Wheels program, and whether you're having the meals delivered at your home or you're going to a setting. You're going to, usually it's a local senior center. You're going to a local senior center to have lunch or dinner or whatever. And I put this on here mostly to remind myself. In terms of whether you're looking at this as a home delivered meal situation or a congregate situation, you probably want to think about having the person go out, because there's something to be said about sitting down with other people for a meal, getting to know people, that socialization piece. So I encourage you to look at that first. Nutrition, counseling, and education services. So this is a nutritional counselor that you meet with who can help you with figuring out what kind of things you should be eating, how to prepare certain foods, and really educating you about nutritional issues. So some of the really good examples are individuals with diabetes, knowing what foods are the best foods to eat, knowing how to eat, the whole idea that with diabetes you shouldn't be eating, big, huge meals. You should really be spacing things out. I've had individuals who had some kind of paralysis who wanted to know what are the foods I should be eating that are going to keep my weight low but still build muscles, because I still want to be able to transfer, but I recognize that in order to transfer to the extent that I'm not bulking up a whole bunch in terms of weight, and muscles are way more than fat, but I want to be sort of muscular but not extremely heavy. So that was one person's question for the nutritional counselor. Cancer, again, big issue in terms of what kind of foods are going to work for them in terms of maintaining their weight, and if they're on chemo, there might be issues in terms of vomiting, what's going to stay down the best. So these are some of the examples of things a nutritional counselor can help you with. We're now on slide 38, wellness counseling. So wellness counseling, if you think about the visiting nurse service, it always has to be surrounding something going wrong, right? So if you have high blood pressure, they can come and check your blood pressure. If you have diabetes, they come and check your sugar, right? But there's always got to be something going on, something going wrong in order for them to come and check these things for you. So wellness counseling is exactly the same service, but on a wellness level. So we're just going to check. We're going to come once a month and check just in case, so that we know that nothing is going wrong. So it really is meant to be preventative in nature. Moving assistance. So remember we talked about you can actually get a mover if you're moving when you're in the nursing home, you're going from one place to another. Well, you can also imagine similar circumstances when you're in the community, when you weren't in a nursing home. So again, you had a stroke, now you're using a wheelchair, and your apartment is completely inappropriate for a wheelchair, and you need to move to an apartment that is accessible. For NHTD only, again, not TBI, you can actually pay movers to move the person from one place to another, move all their belongings from one place to another. You can also, even though I kind of always think about the physical accessibility, it could also be supports are different. So it might be moving closer to a family member or a friend who's going to be able to help out. Anything that's going to improve their independence is acceptable in terms of a reason for using the moving assistance. Next slide. And peer mentoring. For us in IL, this should be something that's familiar. And this is a waiver service where a peer can meet with the individual. And I feel like I'm preaching to the choir, but peers are really great in terms of having a conversation of, I've been there, done that, and things that you may not want to talk with your service coordinator or your transition specialist about, you might feel very comfortable talking about with somebody who's already done that. So, for example, using the bathroom is a big one for individuals who have paralysis. You know, the whole, use of suppositories and, evacuating your bowels and how do you get your cath bag changed, all that kind of things. Someone who's already dealing with that, they might feel much more comfortable saying, hey, have you ever been in the mall and this has happened? So that's what a peer mentor is all about, really talking to someone on that same level who's already going through it and can really give you some good advice. Next slide. All right, so these are just a few of the acronyms, very few. I sent you a whole acronym list, which even the acronym list is by far and away does not have all the acronyms you will run into, but these are just a few of the common ones. Notice of decision, that's an important one to know, the NOD. That is the actual piece of paper that gives you the approval to start waiver services. So that's your kind of what everybody's going for, right? So when you're trying to get somebody out of a nursing home, you're looking to get that NOD. That's the most important piece of paper you can get. CMS, their Center for Medicaid Medicare Services. Dually eligible, this is an important concept if you don't already know it, but when in this context, when you say dually eligible, it means a person who has both Medicaid and Medicare. And the thing you should be aware of is that when you're looking for service providers for these individuals, there are an awful lot of providers out there who, if you call and say, do you accept Medicaid, they will say no. However, if you say, I have an individual who needs services who has Medicare and Medicaid, they will say yes. So just keep that in mind. UAS, we already talked about what that was, as well as the PRI and screen. We've already talked about RRDCs. DOH, just the way you say Department of Health. The discharge planners, the nursing home discharge planners, you're going to be working very closely with them, trying to get information, get scripts, all that sort of stuff. Those are so NHDP, the nursing home discharge planner. PCA, those are the aids that go into your home. CD Pass, I'm hoping that most people are already aware of what CD Pass is, but it's consumer-directed aid services, so it's where the individual is the one who is in control of hiring and firing people. The nice thing about it is that you can have the person that you've hired and trained do things that aides from an aid service won't do. So whether that's administer medications, whether that's driving, whether that's, there's a number of things that CD Pass aides can do that because of the Nurse Practitioner Act, aides that are through an agency can't do. All right, here's an important concept, the difference between a LICSA and a CHA. A licensed agency versus a certified agency. Licensed agencies, generally speaking, are the ones who do aid services. CHAs also can do aid services, but they also do the more medical stuff, so whether that's the visiting nurse, OT, PT, and mental health nursing. And I don't know if everyone's aware that as much as you have mental health or regular visiting nurse services, they also have specially trained nurses that have mental health backgrounds. So if you have somebody who's got issues around that. They can not just check, blood pressure or whatever, but they can also check on them, in terms of depression or anxiety, that sort of stuff. So that is the end of the training. Does anyone have any questions? You can just type them in the question box. I'm not seeing any questions. So I hope this was helpful. Again, it really was meant to be a basic, and we'll be talking a lot more at the January training about what we're going to be doing as transition specialists, but this was just meant to kind of get you all on the same page for the NHTD and TBI waivers. And I've got a question. Does the NOD include the possible reason for denial as well? When you get a denial, I actually don't think it says why you've been denied, but when you get a denial, you can always appeal. And they made a new rule that the service coordinator is not allowed to help the person with the denial in terms of like going with them to the it's not called a trial, hearing, right? You're not allowed to go to the hearing and advocate for the person, but if the person needs help, like say they say to you, I want to write this letter, and they need help with the writing of the letter, you can do sort of that limited thing, because you're just helping with the physicality of it more so than the advocacy piece of it. So it's a sort of weird thing. But no, I don't think it says what the reason for the denial is. But again, any sort of denial, there's always an appeal process for Medicaid. All right, is there anyone else who has a question? All right, so if there's no more questions, I'm going to end the training now, and I will see you all in a couple of weeks at the training. Thank you.